Hi. Let me see if I'm unmuted. Yes. Hi, welcome to our ACI Alliance Tuesday Talk. This webinar is being recorded. We will be your moderators. My name is Molly Thomas and Kristen Ludanowski will be joining us. This is also my husband, Ian. We'll be sharing our CMV and cochlear implant story later during this webinar. And this talk is a part of an ongoing series for parents, adults with hearing loss, family members, and others. So we hope you learn from this session and consider getting involved in the work of ACI Alliance. Next slide. So first, let's review the technology and go over the Zoom settings. That'll be helpful for you. To access closed captioning, first click Settings in the navigation panel at the top of the screen. Then under the Meetings tab, verify the closed captioning should be enabled. If not, click the toggle to enable it. And to ask a question, just use the chat box and simply type it in. Next slide. The American Cochlear Implant Alliance is a unique organization focused on cochlear implants across the care continuum. We were founded because it was felt that cochlear implants fall through the cracks at other hearing health organizations, and we want to focus our attention on improving access to CIs. The mission of the ACI Alliance is to support research, advance awareness, and advocacy. Next slide, please. The CI CAN is the CI Consumer Advocacy Network. It's for adult consumers and family members of recipients, including parents, that's aimed at enhancing and enlarging the broader advocacy efforts with firsthand knowledge of cochlear implants. Personal stories can make the difference in impacting decision makers and adds credibility in our contacts with state and federal representatives on key issues. If you're interested in learning more, please let us know in the chat box and ACI Alliance staff will follow up later. Next slide, please. We also wanted to share a few of the ACI Alliance website resources that are available. Okay, next slide. It's my pleasure to introduce you to our featured speaker today. This is Dr. Cedric Pritchett. He is a pediatric otolaryngologist, head and neck surgeon with Nemours Children's Health System at Nemours Children's Hospital in Orlando, Florida. His scope of practice includes a range of pediatric otolaryngology conditions with particular interest in pediatric otology and hearing loss. He is a cochlear implant surgeon, presently serving as medical director at the Nemours Children's Hospital Cochlear Implant Program and co-director of Nemours Children's Ear, Hearing, and Communication Center. He is an affiliated associate professor in otolaryngology at the University of Central Florida's College of Medicine. Dr. Pritchett received his medical degree and master's in public health from The Ohio State University in Columbus, Ohio. His residency in otolaryngology, head and neck surgery was completed at the University of Michigan in Ann Arbor, and his fellowship in pediatric otolaryngology at Northwestern Universities and in Robert Lurie Children's Hospital of Chicago. Dr. Pritchett is a member of several professional societies. He presently serves on the governing board of the National CMV Foundation and their scientific advisory committee, and is a member also of the EHDI advisory committee for Florida's Department of Health. He is also an ACI Alliance state champ. He's been married for 20 years, has 2 wonderful daughters, enjoys traveling, reading, and is attempting to become a photographer and looking to become more involved in mission work. Please join me in welcoming Dr. Cedric Pritchett.
Thank you for that warm introduction, Molly. It is truly a privilege to be here with the audience that I can see and cannot see, and share some things that are really quite important to our children and to the populations we serve. You know, given my background in otolaryngology and public health, causes for pediatric hearing loss are very important. And over the last few years, I've seen a growing population in my practice of children who've come to me with hearing loss and other challenges due to cytomegalovirus infection. Certainly, it requires a degree of humility to practice medicine and to share and to teach. And the same is true with cytomegalovirus. There's been a tremendous amount of work over the last 40 to 50 years that have occurred in this space. Very informed and very smart, skillful physicians and scientists have got us to the point where we are. And yet there are lots of questions that still remain. And while we haven't answered all those questions, and we are disappointed in that. We certainly aren't discouraged. This journey continues, and I hope for these next few minutes you'll enjoy and find meaningful some of the learning opportunities and experiences we have gained in our journey thus far. Oops. So over the next few minutes, we hope to delve into just some of the incidents of congenital CMV. How does it contribute to newborn hearing loss? What are some of the risk factors and prevention strategies that exist? Understanding what are the categories for treatment and management options? What does the future look like? And then how do children with CMV perform with hearing loss and after their cochlear implants have been received? And we hope that you'll find this, again, useful. So what is CMV? You know, the big three letters stands for cytomegalovirus. And this is a virus that is a family member of the herpes family. And that in itself is part of the problem. You'll recall that the herpes virus is rather large, and some of the more common offending factors are herpes simplex 1 and 2, Epstein-Barr virus, varicella virus, human herpes viruses. These cause things that continue to be scourges to humankind. But a unifying theme for them is their ability to become latent. And by that, these viruses can remain dormant in particular parts of our body where very low levels of replication occur. They don't die, they just kind of hibernate. And then for reasons that aren't always clear, they can become reactivated. With the cytomegalovirus, the dormancy or the latency really involves the bone marrow and monocytes, but then they can be reactivated. CMV is the largest in that family of herpes virus, hence the term cytomegalovirus. Next slide here. So why is CMV relevant to us is part of why you're asking this question. And I should spread the context here by saying this is a very common viral entity. It's actually perhaps the right way of looking at it is not a matter of if, but a matter of when we become involved in this. By the age of 40, between 50 to 85% of the adult population have contracted this virus and have it. In the immunocompetent part of the population, those whose immune systems are working well, this tends to not cause a lot of problems. Maybe a little cold symptom, and in the worst case scenario, maybe you feel like you have the flu. It accounts for a substantial part of mononucleosis type symptoms. But the immunocompromised, those with weaker immune systems, and in particular, those with transplants who are on medicines which suppress their responsiveness. These are challenging patient groups that have to be very, very careful because this can lead to severe illness and in some cases death. But the group we are interested in today is that group, that perinatal group, the children who are being born in early and who are still developing in their mother, because they have a particular vulnerability to this entity. CMV is part of that TORCH acronym that we use to describe viruses which can cause congenital defects in children. And we're all familiar with toxoplasmosis and not being around kitty litter or herpes, but the C in this is actually cytomegalovirus. Well, how common is this? We would say that incidence varies somewhere between 0.5% to 2% of the population in the United States. And so that translates to nearly 20,000 at a minimum, but up to 40,000 children are born with this. 1 in 5 of these children will actually have a permanent health consequence that will affect how they engage and interact with their environments. Some of the more common themes seen involve the vision, where you can get inflammation and damage to the retina or cortical blindness. Intellectual disability, seizures, and cerebral palsy are also entities that cytomegalovirus can cause. However, it's the hearing loss and the balance system that perhaps is the most noticed and observable for children with congenital cytomegalovirus. CMV can account in some studies up to nearly 20% of permanent hearing loss in newborn children. So certainly an entity that deserves our attention. Historically, we've categorized cytomegalovirus infection, congenital cytomegalovirus infection, as children where there's visible evidence of disease, and then children where it remains more innocuous and hidden. And we call that symptomatic and asymptomatic. Now, we realize that may not be the most accurate description, but that's the language that a lot has been written about. And 9 out of 10 children, CMV is not realized because it's an asymptomatic presentation. That child may have some blindness, they may have some hearing loss, but we wouldn't necessarily notice that. The other 10%, the symptomatic, are children who will have some of these common system organ failure involving the liver or the spleen or the bleeding system, or you get thrombocytopenic like this particular picture here. Those children can be born early. They can have seizures and cerebral palsy and can be quite ill and have a higher than desirable rate of mortality, unfortunately. So what and how does the distribution of hearing loss related to CMV compare to other causes of CMV? Well, a well-regarded study kind of pegged that at 1 in 5 children who have permanent congenital hearing loss can be attributed to the cytomegalovirus. That's actually quite a bit, and it puts it as the most common cause of congenital hearing loss that's not of a genetic etiology. As those children grow up and pass through infancy and toddlerhood, we see that there actually is a widening of the pie in the distribution that's related to cytomegalovirus. Up to 1 in 4 children at the age of 4 years of age are thought to be related to that. And that's because of the ability of this virus to actually cause a delayed onset hearing loss. And that's something that we'll touch base on a little bit further along. The distribution of CMV is certainly not homogeneous. And as you look across the country, this is data provided by the CDC, you'll see that the darker shaded areas are areas and regions where there's a higher prevalence of congenital cytomegalovirus. The lighter areas, the upper Midwest and such, are areas where the distribution is not as high. I'm in Florida, obviously, and so you can see for me that we are one of those areas that are rather dark. We also see that the demographics of children who are affected by this is far from equal. African Americans and those of multiple races have the highest distribution, followed by Hispanics, of congenital cytomegalovirus. And while the reasons for these are not completely understood, we certainly see that this is a pattern and a finding that has considerable concern. So how is the CMV virus acquired? So the virus is transferred in ways that are similar to other viruses. And in particular, this is spread by bodily fluids. We believe, based on years of research, that in the particular mother-child interaction, congenital CMVs largest, not victims, but the largest transmitters are those children who are in their younger years. And children under the age of 2 really, for reasons that aren't clear, can keep this virus and shed it for up to 6 or 7 years after they've contracted it. This virus is then eliminated in saliva and urine. And in bringing an individual into contact with that, you certainly are vulnerable and at risk for acquiring this. Approximately 1/3 of children under the age of 5 will carry this virus, and it can be easily spread. Approximately 30% of mothers who have a child who is infected with congenital CMV, themselves will then go ahead and seroconvert within a year. So in other words, if you have a child who's been exposed to the virus and contracts it, being around that individual over time puts you at a higher risk of contracting that. And we want to talk about ways that that can be prevented and reduced. While there certainly isn't a guaranteed and prophetic relationship in how a mother and baby are going to experience this, there are some rules of thumbs we see. Earlier in pregnancy, there is a higher risk of individuals who contract CMV to result in a child having developmental abnormalities. We know that early in pregnancy, that's where the organ systems are facing. And so unfortunately, contracting that early relates to a higher rate of fetal damages. Later in pregnancy, the risk of transmission is more likely, but the severity of that tends to drop off. We think and classify the timing for cytomegalovirus infections as primary and reactivation or secondary. In the primary situation, this is the first time a mother would contract this. And in that case, there is a higher transmission rate and a greater risk of that child developing some of those complicated factors that will result in perhaps an early delivery or needing to be in the neonatal ICU because of some of the other body systems affected. With that being the case, the majority of CMV congenital infections really come from the reactivation and secondary activations. And that's just a numbers game because there are more individuals who have been exposed to this over time than are newly acquiring this every year. And so the majority of these congenital CMV infections are from those who've had this and then are reactivated. While sometimes we find it a surprise that a particular family has this, there are some risk factors that we see in the literature and can see in our practices. Employment is one. Not all the employment venues are the same, but given what we've just recently discussed with toddlers and infants having a higher risk of this in the daycare setting, working in daycare puts one at higher risk of that 2 to 3-fold of acquiring CMV. Healthcare itself is not an independent risk factor for increasing one's exposure to cytomegalovirus. If an individual is a recipient of a blood transfusion, that is something that can put them at increased risk. Multiple sexual partners, as we saw before, this is a virus that can be transmitted through bodily secretions. The African American and Hispanic population, those of a lower socioeconomic status, and women who are having their first pregnancy in their teenage or early 20s are also at higher risk for this. We could also add, and some have discussed, children who are second born tend to have a higher incidence of this congenital CMV situation. So how is cytomegalovirus diagnosed then in the mom and in the fetus and in the newborn infant? It varies a little bit. Routine screening for mothers to determine if one has been exposed to this virus or not is not recommended. However, if there is a situation where a pregnant woman becomes sick, it is encouraged that they seek advice from their obstetrician about being tested for this. And the reason routine screening is not recommended is the presence of a positive CMV exposure doesn't necessarily tell us who is going to have a pregnancy that is then complicated by CMV or not. For the developing child, there are some characteristic findings that can be seen on an ultrasound that would be consistent with the congenital CMV infection. Once the child is of a particular age, amniocentesis can also be performed looking for the presence of viral DNA. What is particularly relevant for our patient population, though, are once babies are born, how do we determine if they've been exposed to CMV and have a risk of developing consequential hearing loss? Well, what has become clear is that over time, given the prevalence of this condition, waiting until a child is older can blur the lines and make it unclear as to whether or not this was something they were born with or an entity that was required after birth. And so the recommended approach is testing children prior to 3 weeks of age for the presence of the virus. The sources and specimens that are most routinely used are urine and saliva. But blood can also be used. And the fact that blood can be used does allow one to, in cases of question, pull the blood spot or Guthrie cards that are retained at many of the states across the country to check for the presence of that viral DNA there. Once the diagnosis of congenital CMV is made, there are a number of specialists that will be helpful for the developing child and their family, including infectious disease, ophthalmology, audiology, otolaryngology. I believe it's helpful to think about cytomegalovirus as a public health problem. And so for the public health professionals, that conversation is often framed in language that seems a bit unique, but it really helps us look at it through the lens of what we can do to prevent this. And so there are three levels of prevention. There's primary, secondary, and tertiary. Primary prevention really is that attempt to prevent anything from happening out of the gate. Secondary prevention looks at detecting the presence of an entity early before the stages of disease become apparent. And tertiary prevention could also be termed as treatment. How do we then minimize the impact that a particular entity, if untreated, will cause? So primary prevention is really where we would love to be when it comes to cytomegalovirus. And one will right out of the gate think of, well, vaccination, because we have vaccination for so many other infectious entities. And I know just in my lifetime, chickenpox became one that went from something we all kind of accepted and as a initiation into being humankind to now a vaccine being available. While there have been several vaccines that have been worked on with different components of the CMV virus, and there are ongoing clinical trials at this moment, there is not a vaccine that's been approved for routine use in humans to prevent this. Part of the challenge with designing an adequate vaccine for CMV has to do with the fact that we are dealing with that herpes type virus with its ability to become latent. And so the targets for this vaccine to be effective are you preventing the initial contraction of the virus, or are you preventing the virus from being reactivated? And those are interesting and involved processes to navigate. Another very important aspect, though, of primary prevention involves just the education and appropriate hygiene. And I say that not trying to be insensitive. I mean, I believe as adults, we all believe we're healthy and clean. But it is really important to emphasize that when there is a exposure to a population that has such a high prevalence of CMV, meticulous hand washing becomes important. Every time you change a diaper or wipe down toys, clean up the table, these are things that we would not necessarily think about. It also becomes important to avoid saliva, and so practices perhaps of cleaning the plate of your child after a meal, sharing drinking utensils, sharing eating utensils, kissing your child on the lips or the face. These are all things that seem simple and innocent, but very well can be the method in which this CMV can be shared. And there is data that describes how when women in particular become aware of this and how this can affect them, these behaviors result in a decreased incidence of CMV and congenital CMV. Right, let's see. Secondary prevention really looks at, now that CMV is present, how do we detect its effects early and minimize that? And there have been both informal and formal position statements. You'll see here by a consensus group on congenital cytomegalovirus and the European Society for Pediatric Infectious Diseases, both putting out statements which recommend routine audiologic evaluation every 3 to 6 months for the first 4 to 5 years of a child's life, ophthalmologic evaluation, developmental assessments, following up with a pediatric infectious and disease expert. These are entities and processes meant to try to determine as early as possible some of the consequences that can result from a congenital CMV infection. The Joint Commission on Infant Hearing has adopted their most recent position statement in 2019 to reflect the need for ongoing regular evaluations from a hearing perspective for a child who has been diagnosed with congenital CMV. Now we can look at the treatment aspect or tertiary prevention, and really this can be divided into how do we address the causes and then how do we address the effects. There have been some clinical studies that have looked at the presence of immunoglobulins and antibodies in treating CMV, but as of yet, these remain experimental in nature. And some of the results have been mixed and in other cases disappointing. And so that is not technology or interventions that are routinely available for use. Antiviral treatment, on the other hand, does have a role in children with congenital CMV. And while we don't have the time to go into the depths of this, two antivirals in particular, ganciclovir and valganciclovir, have been well studied in their effects on children with congenital CMV. When one talks about who is an appropriate candidate, there are a number of factors, including whether or not the child is seen to be symptomatic or asymptomatic, how early this is detected. One has to think about what are the consequences and potential side effects of the medications used, and how long should therapy be initiated. Several years ago, the realization that ganciclovir, when used in children who have congenital CMV that's symptomatic in nature and are started within the first month of life, were noted to not have a deterioration in their hearing loss if treated for 6 weeks with this IV medication. But there were some real side effects to that affected white blood cell health and overall health of the child. And so that became medication that was then used, but cautiously. And valganciclovir, which is the prodrug form of ganciclovir, has taken its place really as kind of a standard of care for the symptomatic child with congenital CMV. This is much more tolerated with fewer side effects. And if initiated early, is often used up until about 6 months of age. There's also good data that shows that children who have been followed up to 2 years of age have noted to have significantly benefit from a hearing perspective and a neurodevelopmental perspective when valganciclovir is used. The long-term 10, 15, 20-year data is starting to show that some of those benefits may not be quite as lasting. But as we know in children, part of what our challenge is to provide them the greatest access to sound during that period where their brains are developing and they're literally just sponges waiting to absorb information. Okay. So CMV and hearing loss itself is really quite variable. And if there was a way to describe a hallmark appearance of cytomegalovirus-related hearing loss, that really is it, where sometimes it just doesn't make sense into how it presents. What you'll see here are several different audiograms that highlight that point. If you can appreciate the blue X's, that represents the level of hearing in the left ear. The red circles or triangles represents the level of hearing in the right ear. And that black solid line represents the level above which you would like to see those X's and triangles, which means normal hearing. And so sometimes you will have an asymmetric hearing loss where there's hearing in both ears, but not equally distributed. Other times you'll have single-sided deafness where essentially the hearing is normal in one ear and profoundly lost in the other. Hearing loss with CMV can fluctuate. It can get better and then turn around and get worse without apparent cause. And it can be progressive over time. In the asymptomatic child, on average, it's felt to lose perhaps 1 to 3 decibels per year for the asymptomatic child and 1 to 4 for the symptomatic child. But another puzzling reason or another puzzling demonstration of the CMV-related hearing loss is its ability to be delayed in onset. And this is a challenge and this is sobering because a child can actually pass their newborn hearing testing and then develop hearing loss that can progress to a level of severity to profoundness over time. And we'll talk a little bit more about what those findings have resulted in and what's happening across the country to try to address this congenital CMV. Well, what is the mechanism of loss for CMV-related hearing loss? Well, unlike what we see in genetic hearing loss, where often there's a specific protein or structural component of the inner ear mechanism that results in this, for CMV-related hearing loss, this is multifactorial. And so it has, over time, we've seen through a combination of cadaveric evaluations and pathology reviews to animal models, it appears that there is some inflammation that can involve certain structures of the inner ear mechanism. mechanisms that are responsible for driving that electrochemical gradient. But that inflammation can also involve the spiral ganglion, where the cell body for the hearing nerve actually is. There can be death to those nerve fibers that are there. And then finally, there can be injuries that result in a compromised blood supply with loss of nurturing vascular structures to that inner ear. With that being said, when you look at the largest cohorts of studies over time, there do appear to be some patterns that one can expect and can counsel their families about when it comes to CMV-related hearing loss. Once again, you'll see we divide this into the symptomatic and the asymptomatic distributions. And on average, symptomatic children are more likely, 1 out of 3, to experience this compared to 1 out of 10 for the asymptomatic child. The symptomatic child is also more likely to have an earlier onset, under 3 years of age, compared to closer to 4 years of age for the asymptomatic child. Both groups can have bilateral involvement, though once again, the symptomatic child is more likely to have both ears involved. There appears to be an equal predilection for either group to develop hearing loss considered in the deaf range, but the symptomatic children are more likely to develop that insidious delayed onset option. Both groups can have some progressive components, and hearing loss can fluctuate in both groups. If we look at the single-sided deafness population for children, this is an area that's generating more and more attention over time. And we know that these children do have some deficits that can affect how they learn and develop and then perform. Congenital cytomegalovirus is certainly one of those entities that should be brought up in conversation as a potential cause anytime a child has either single-sided deafness or the asymmetric hearing loss. And while there's variability in the cohorts that are published in the literature, it appears that that group of children with congenital CMV may be the second largest group of explanations behind single-sided deafness or asymmetric hearing loss, where children with anatomic defects such as the deficiency of the cochlear nerve are the most common cause that are there. It was a little challenging to try to put my hand on a specific number to guide what is the likelihood of single-sided deafness in children with congenital CMV. But what we do see is it looks like, once again, there's a difference in children who are symptomatic, where it may be 1 in 6 children who have hearing loss in a symptomatic state can have single-sided deafness. But that number is quite a bit larger or smaller, depending on how you look at it, near 2% in the child who has asymptomatic hearing loss, and the likelihood that they will develop single-sided deafness. CMV doesn't spare the other component of the 8th cranial nerve, and that's the vestibular nerves. The vestibular system, of course, is responsible for balance. And this is an area of ongoing research that we're realizing, even more common than we would have anticipated, children with congenital CMV can have balance and coordination issues that may not always present right out of the gate. You can have children who have vestibular challenges where their hearing loss, where there is no hearing loss, which can be interesting and is leading to a growing number of individuals asking for balance evaluations for children who have CMV, just like we are testing for hearing loss over time. So how does a child who has CMV-related hearing loss that progresses to a level that they become a candidate for a cochlear implant perform? And how do they perform relative to children who have hearing loss in the same range for other conditions? Once again, this is an area of active research. Some of the earliest studies were published in the 2000s. Most of these have been institutions across the country and around the world reporting on what they've seen in their own practice. Most of these are what we would consider retrospective studies, where we look back to see what's happened. There are one in particular that try to design a study to actually answer this question thoughtfully. Often these children are compared to some of the other genetic causes, and in particular, connexin 26, which is the most common genetic cause for hearing loss, to see how these children do over time. And what we've noticed is a few take-home pearls that are really helpful as we have conversations with parents or who are asking about what should they expect from their child. First and foremost, every child is different, but on average, we see that a child who has hearing loss in a range that would make them a candidate for a cochlear implant receives a benefit from that. Available evidence, though, does suggest that children who have CMV and are implanted do have an increased risk of poor language production, particularly if the brain is obviously involved with this. Now, we know, of course, CMV is an infection that affects the central nervous system, and so that makes sense. And what we notice is there is a difference in that asymptomatic child versus that symptomatic child. Now, the encouraging news is that a lot of the studies that have been assessed notice that while there were differences in how children progressed, over time, children with congenital CMV started to approach levels of their non-CMV peers. And so it didn't seem so much that that ceiling had a hard stop, discriminating against those children with congenital CMV, as much as their journey to get to that point was longer. And so the perspective is our expectation should be for children to make benefits from this, but the time it takes for a child to achieve some of these are going to be delayed. And that may mean more resources, increased length of the therapeutic benefit, certainly patience without discouragement, but also realizing that in a developing brain, there are some benefits by earlier access to sound and progression over time. And so if one makes progress promptly, it's a little easier to evaluate how they're doing. Look at this next thing. The final piece I'll kind of say about that is because we are still understanding what it means to have a child with congenital CMV and how these classifications of symptomatic versus asymptomatic play, there are calls to investigate this further. The ACI actually has part of the theme for this upcoming conference this spring that's dedicated to bringing professionals together to talk about what they're seeing in their practice with children related to outcomes who have been implanted with congenital cytomegalovirus. What is still needed? Did I skip a slide? Yes. What is still needed? To be honest, quite a bit. We are still understanding what are the consequences of CMV on so many levels. A lot of individuals who have been asking for more robust testing are faced with the question as to what is the financial consequence of doing some of these things and what benefit is going to be made. Well, we need to ask that question. And in order to ask that question, we have to clearly identify who are the children who have this so that we can follow them to provide good information. There's plenty of room to improve modalities that are going to advance the prevention of cytomegalovirus infection initially and preventing reactivation of that for those individuals who have it. It's still relatively expensive to test for CMV, and that creates a barrier into wide embracement of universal testing for these groups of, or not for these groups, for children across the country. And then finally, the ability to have therapeutic drugs that are low in their side effect profile, but high in their ability to either reverse or significantly delay that progression in some of these neurologic deficits involving vision or hearing or balance that exist. And finally, of course, there needs to be efforts made that recognize that a child who has hearing loss, whether it's one ear or both ears affected by CMV, have need of intervention and services that are going to allow that child to achieve their optimal outcome. I think it's important to think of CMV in the context of an attack on the brain, an attack on the nervous system. And our special senses help us experience that. And in the same way that we really rally around a stroke victim, that same space and opportunity exists for a child with congenital CMV. So I think I'm going to take a pause at this point in time. Not having an audience, you kind of just get talking going. So I hope I haven't gone too fast and shared too much information, and certainly wasn't presented in a confusing manner, but I know there'll be a little bit of time to ask for questions. But I'm going to turn it back over to our moderators now for the next portion.
Thanks, Dr. Pritchett. Again, I'm Molly. This is Ian. We're going to share a story about our daughter, Maddie. So you can see all of her pictures through her stages of life up on the slide. And we'll just kind of give you a little bit of our story. So Maddie was born on March 11th in 2019, and she was beautiful and inquisitive. When she was born, we hardly noticed any signs of hearing loss. We don't have any family history. We don't even really, at the time, didn't know anybody who was deaf or hard of hearing. So we had no heads up to even be thinking that that could be a possibility. After we learned in the hospital that she didn't pass her newborn hearing screening. We were told after that screening that it was probably just because she had some leftover fluid in her ears from the labor process. So they told us not to worry about it too much, just come back for follow-up testing. So if you fast forward through that follow-up testing all the way to her auditory brainstem response test, which is the test they do to discover any hearing loss, we received Maddie's official diagnosis for moderate to severe hearing loss in May of that year. So the shock of her hearing loss hit me pretty hard on the first ABR because we were both really unprepared. I thought initially the test was just a formality. I'm even a nurse at our local hospital, but pediatrics and particularly pediatric ENT and audiological needs were very far outside of my knowledge and scope of practice. So I felt in that moment when we received that diagnosis, I felt pretty lost and without a plan. We managed to get hearing aids for Maddie in August of 2019, and thankfully soon after we met Dr. Pritchett at Nemours. He was really patient and really diligent with us. I remember when you were answering all of my questions, you even waited for a while so that more questions had time to come to the surface. But he gave me multiple roadmaps for Maddie's possible future needs and future treatments. In our first appointment, we even discussed how to retroactively test Maddie's blood spot test because by the time we saw Dr. Pritchett, Maddie was far and away outside that 3-week window where we are able to get a sample to test for congenital CMV. When we got the results back for the blood test, I was shocked again, not necessarily because I wasn't educated at that point, but just because I was so floored that this was such a common virus that people can carry around even without knowing, but that I wasn't really educated when I was pregnant with my OBGYN or really any like postnatal care. So we, after she was diagnosed, we tried with one of the infectious disease doctors at Nemours, we tried a valganciclovir trial to see if that would slow or stabilize Maddie's hearing loss. But COVID came right in the middle of that. So the drug became available almost in every pharmacy in Florida that was reallocating resources to deal with COVID. So by that time, by early 2020, everything was shutting down. Our ENT and audiological appointments were being delayed. When we finally were able to get Maddie back in the summer, we realized that her hearing loss had deteriorated to profound loss. It was at that time that we began switching course to pursue cochlear implants. After some insurance battles and delays, Maddie became the first bilateral simultaneous cochlear implantation at Nemours with Dr. Pritchett in Orlando. So her surgery was in September, and it was long, and I know there was a lot of hard work put in by Dr. Pritchett and then the nurses and anesthesiologists that participated in her care, but Maddie did amazing. She, even after the first few hours of surgery, I remember Dr. Pritchett rounding, and Maddie was eating as much as she could, mac and cheese and French fries, really anything carb rich, like she hadn't had surgery that day. So between all the care that she received and just her resiliency, it was like she did awesome. So Maddie's cochlear implants were activated the next month. And that appointment was really fun. You can see one of the pictures on there of her just being silly. She was trying out her voice in all different ways as her brain was figuring out the new stimulus of sound that she was getting from her implants. Maddie's always liked to hear. She's always singing and playing. Now, as a almost 4-year-old, she likes to joke and has a vibrant imagination. And these days, once you get her talking, she's practically a runaway train. And it's one of my favorite things in the world to this day. Whenever we have a loud noise in the house or a timer goes off and she looks at me and she says, "Mommy, did you hear that?" So I'm so grateful for our cochlear implants. And I'm really grateful for this congenital CMV diagnosis. For us, it means more access to the care that we need, that she needs. It also means tempering expectations, like Dr. Pritchett had discussed. And it means that we have a plan. We have talked through this presentation that there are needs for more standards of care with this particular population of kids. But I'm grateful for the research that's been done so far, to be able to be with Dr. Pritchett and all of our team at Nemours, who has been blazing a trail in this particular arena. I'm really glad because it was also part of the reason we found out Maddie needed glasses, which I think completes her look as one of the smartest and coolest little girls that I know. I want to acknowledge too that there's a lot of families out there with children who are more affected by this virus than even we were. And that those parents, just like us, were caught unaware that it shouldn't be this way. So I really think with some of that hard work we've discussed, some greater awareness that kids can be getting the treatment and therapeutic interventions that they need even faster. So grateful. Thank you for listening to our story. I'm going to pass it over to Kristen.
Good afternoon, everyone. My name is Kristen Lewandowski, and this is my Chelsea on the screen. Our story's a little similar, a little different in some ways from Molly's story. So Chelsea turned 2 last month, and she's probably one of the absolute happiest babies I've ever met, despite everything that she goes through. She's always smiling, she's always giggling. She's had a very long road so far. So she was born 10 weeks early. She was only 2 pounds, 2 ounces when she was born, and she tested positive for CMV shortly after birth because there were concerns with her platelet count. And then probably about 4 days after she was born, she got the diagnosis. She received blood transfusions when she was in the NICU, and she was started on valve encyclopyr pretty quickly. And she stayed on that for the recommended 6 months. She ended up being in the NICU for 66 days before she was discharged home. Prior to the diagnosis of CMV, we had never heard of it before. We had absolutely no clue what it was. We didn't really know what to expect. We were trying to be the optimistic, hopeful parents in the NICU and saying, hopefully this is the worst of it. There'll be no other, impact or symptoms. And I remember a nurse saying, there's always something. And that kind of stuck with me even 2 years later to say that. It kind of gave us the awareness that there's more to come. But since learning about it, I'd say there's been just an absolute wave of emotions for us, at least for me. There's a lot of anxiety about the unknown, a lot of fear about what challenges she's going to have in life and what she'll have to go to kind of catch up with her peers. And also just a lot of stress. As parents, we're both working full time. We have another daughter, and we're trying to manage all of Chelsea's appointments and her care needs from day to day. So it's very stressful to kind of go through that process as well. And for me, especially, I have a lot of anger also because I had never heard of CMV before. And being in Florida, I was thinking back to Dr. Pritchett's map. Florida was one of those darker purple states where the prevalence is pretty high here. It's like, why wasn't this ever mentioned in an OB appointment and a pediatrician appointment, especially since we have another child? So just a lot of anger because I don't understand why there wasn't a single mention of this virus during either of my pregnancies, and I got a lot of education, a lot of reading materials, probably 100 different papers. I read every single one of them, and I don't ever remember seeing it. So there's of course no way to know how I got CMV, how transferred to Chelsea. Was it a primary infection? Was it reactivation? When did I get it in my pregnancy? I do remember being sick with a really bad head cold the week of Christmas, and it was just shy of a month later that we ended up having Chelsea early. We don't yet fully know the extent of the impact that CMV's had on Chelsea, because unfortunately only time will answer that for us. But so far, as of today, we know that the virus did have some negative impact on her brain. And we know that she has the sensory neural hearing loss. For her, her biggest challenges have been connected to the hearing loss, going through that process. And Dr. Pritchett and the team at Nemours have been absolutely fantastic, helping us go through that process, being our guide, educating us, really, supporting us and being a champion for Chelsea. She also has some significant GI issues that result in feeding issues that have been a big challenge. And there is a train of thought that there is some connection between some of the challenges we've had on her hearing side, with some repeated ear infections and the GI issues kind of being linked. And we don't really know if those GI issues are related to the CMV, if it was because she was born premature, or a combination thereof. And then Chelsea does have some delayed milestones. So as I mentioned, Chelsea was diagnosed with severe to profound sensory neural hearing loss. We actually got the diagnosis when she was still in the NICU. And for me, learning of her hearing loss was one of those conversations I don't think I'll ever forget. I actually wasn't at the NICU that day. So my husband was there and I was there by FaceTime. And I just remember feeling very stunned. I didn't know what to say. I didn't know what to do. I remember Adam saying, to the doctor that was giving us the diagnosis, that I just needed time to process. And I remember one of us asking, the very basic question, does this mean our daughter's deaf? To which we were told, yes, she'll likely be a good candidate for cochlear implants. And I think that was the first time I ever heard of cochlear implants. I don't know that I'd heard about them before. She received her first hearing aids when she was about 4 months old, adjusted. And then we were told with the hearing aid, she still had a pretty significant hearing loss, about a moderate hearing loss, as well as a latency. So she'd have a hard time differentiating at the end of words, kind of like the S sounds between singular and plural. She had her hearing aids for probably about a year, and then she was implanted about 16 months old, adjusted. And based on testing, now she seems to be, around the normal range of hearing, and they're seeing improvement in her latency, which is fantastic to hear. And overall, I just say the journey to where we are now with her hearing has been one of the quickest, but the longest journeys I've ever been on. And I, of course, would like to see her further along because I'm anxious. I want to see her talking. I want to see her caught up with her peers. But, overall, I'm very happy with how she's developing so far. It's frustrating at times because, a 2-year-old, there's something in my hair. I just want to take it off. I want to take it off. So I think one day our audiologist, when she was looking at her hearing aids and her cochlears, kind of looking and seeing how much wear time she had said that she took them off 75 times one day. So 75 times a day, we put them right back on her head. We try to be very persistent, and it seems like our persistence with keeping the hearing aids on and now the cochlears is paying off and has really helped her. Based on what we get from her and the feedback from her treatment team, she seems to be responding really well. And then again, just the team at Nemours has been just absolutely fantastic, incredibly supportive, and I'm really optimistic that we did choose the right path for Chelsea with the cochlear implants. I do wish that we had been able to get them sooner, but she's babbling now, she's making more sounds, and it's exciting to see her finally, making a lot of headway forward. And just one of the last questions I was answered is, what would I like other families of little ones affected by CMV and hearing loss to know? And I don't know if there's anything specifically I'd want to share to make sure people knew, because everyone's journey is very different. But I would want to offer just encouragement to never stop advocating, and to never accept no, to never accept delayed timelines. Don't accept anything except for the best care. And if you're comfortable, take advantage of opportunities like this and to be involved in research, because everyone's journey is different, and there's just so much opportunity to learn from everybody that's affected by this. And hopefully one day the impacts from CMV won't be as significant for somebody else, and there'll be a vaccine, and this level of research and conversation won't be as necessary. So I just want to thank Dr. Pritchett and his team and the ACI Alliance for giving us the opportunity to share our story.
We'll go ahead and take your questions now. Oh, sorry, Dr. Pritchett, you're going to finish. Yeah.
I just wanted to add that Molly and Kristen, it's been special to share with you in the journey for both of your children, and the ACI giving us the opportunity to partner in ways that it's not always where a provider and a parent can share the screen to speak about a journey to help a child. So that's been fantastic. And Kristen, to your last point, never stopping the efforts to advocate for your child are important. I think that translates into some of the ongoing conversation that's happening around the country, which is given what we know and how children are affected and how this is an entity that affects more children than Down syndrome or spina bifida, or fetal alcohol syndrome, how are we identifying these children? And there are a number of states around the country who have worked to change that. The initial state was in Utah with the cytomegalovirus public education and testing bill that was passed in 2013. Now, 10 years later, CMV legislation has been presented in 18 states. It's proposed in another 4 because of what we're seeing and the experience that both of you have articulated just in a most touching manner. Minnesota is the first state in our country has moved forward for universal CMV testing, trying to capture absolutely as many children as they can to provide families and parents with information, providers with information, and allowing them to make some decisions on how to manage their child and what kinds of things to look for in the future. And so just to wrap up briefly with a summary before we take your questions, I hope those who are watching and joined us today and those who will watch in the future can appreciate that congenital cytomegalovirus really is a common cause of hearing loss, despite how it may be something you've never heard before. And not just hearing loss, but disability and communication delay across the pediatric population. Children who have this can have fluctuating symptoms, but quite a few develop permanent neurologic sequelae. And in order to know if a child is experiencing that, regular assessments need to be made, similar to what happened with regular assessments being made with newborn hearing screening. We believe that early detection of CMV will put that child in the best place and position for early intervention and really support those goals to maximize their speech and communication skills. CMV does affect not just the hearing, it's the entire nervous system. And so it's important to have realistic expectations as you consult with your therapists and audiologists and surgeons and other clinical care team members. Don't give up. It will take a journey, but the efforts are certainly worth it for the benefit to provide your child those resources which give them the best shot at reaching their potential. And then finally, it will circle back around to a comment made earlier. It takes humility to practice medicine. We don't know everything that we would like to know. And while it is disappointing we haven't accomplished more, we're not discouraged. We will continue to move forward. And in the space of congenital cytomegalovirus, moving forward with parents and the community, in addition to the scientists and physicians. And I believe, Molly, that those are the last comments I had. I'm happy to turn it back over to you and Kristen to moderate any questions that are there.
Sure. So we have a couple of questions that came in. Dr. Pritchett, I think the first 2 are probably more for you. How do they record congenital CMV infections per state, with many states having no requirements for testing? And why is the screening not required on the newborn panel?
Okay, so the answer to that would depend on the particular state that the questionnaire is coming from. Some departments of health and some early hearing and detection intervention arms of the Department of Health are prepared to record that. We know here in Florida, our CMV bill that was passed this year does require CMV to be a reportable illness now that is then tracked with the EDI and the Department of Health. Why CMV is not a universally tested question is one that we're still looking to answer. There has been an effort to propose that be considered. It's a fairly involved process that takes some time at the federal level for the panel on recommended universal testing to issue a thumbs up and a green light for that to happen. There was an application from the National CMV Foundation last summer that put that ask there, and the response basically was, we need more information. And so there are efforts to try to get more information. One of the challenges in the CMV space is if you're not looking for it, you're not going to always find it. You'll find the 10% who have it, but what about the 90% who don't? And so we are looking to see some organizations support research projects that allow us to be intentional in asking some of these scientific and financial and developmental questions that demonstrate the impact of this condition on our society is larger than we anticipate.
Our next set of questions is asking about why is it not required for OBGYNs to educate new mothers on CMV prevention? Speaking about, just the increased dangers in the community, especially if you work in a daycare setting or have a child in a daycare setting. And what is your experience with working with obstetricians in terms of educating them and providing information to them to relay to their patients? How can audiologists work in a pediatric setting to help spread this information?
Yeah. I'm very confident that the men and women who are taking care of the population in the United States and around the world are interested and committed to best interests. So I don't believe that there are OBs who don't want to provide the best care for their mothers and consequently the children that are born. There are position statements that encourage providers to share information, and there's ongoing efforts and collaborations across different professional specialties and organizations partnering with providers from different specialties, pediatrics and obstetrics and audiology. I know here in Florida, we've had collaboration across the state where infectious disease specialists and obstetricians present grand rounds for their groups to help individuals understand that there is something that can be done. I believe, it's worth stating that if one is not careful, you can be led to maybe see this that, well, what can be done? And are we just testing and then we can't offer? And I would really make the point that parents would appreciate knowing it gives them an opportunity to plan and prepare. And there are those developmental supportive strategies with the therapy that help our children who have this reach their potential, right? And then, of course, knowing that a child is at increased risk means that child should be followed closer than others. And what parent would not want to do that? So I believe the opportunity for all of these organizations is going to strengthen, and you're going to see even more support in that space. But I've personally been impressed with the obstetricians that I've talked with on these topics.
The next question is directed towards myself and Molly. Are both of your children enrolled in speech therapy following implantation? Can you discuss the importance of this following implantation? For Chelsea, she's been involved in speech and language since before she got her hearing aids. So we have a teacher through Orange County that comes to our house every Monday for speech and language. And then we also go to Nemours once a week for ABT therapy. She's been going one to two times a week, every week since before. Like I said, before she even got her hearing aids. And I think it's incredibly important because even when she didn't have access to sound, because it was teaching them the building blocks of communication. So whether that be using sign or other methods of communicating, like pointing or repetition or mimicking like basic behaviors. So for us, it was important also to educate us as parents of what to expect, the different types of language and ways to communicate with our child until we got to that point.
Our experience with speech therapy was really similar to Kristen and Chelsea. We also had Maddie in speech therapy since before she was implanted. With hearing aids, we also benefited in our county. We have like the early intervention, like federal program that they have here. We also did the same thing where we had someone come to the house or even go to her daycare for once a week for like 30 minutes, and then doing an hour of AVT therapy, which is auditory verbal therapy, if you're not familiar with that. That, like Chelsea's or like Kristen said, that really trained us as parents because we needed to be like the primary therapist for Maddie at home. So we really needed to know what we were doing. We live in Lakeland, which is can be an hour and a half away from Nemours. So we actually did some of our therapy virtually, which really put the burden of responsibility on us as parents to be able to just primarily be the ones interacting with Maddie because our therapist couldn't physically be there. So in some ways that was actually really good training, I think, for both of us to be able to implement the strategies that we were learning in those sessions. I think without therapy, kids who are implanted with cochlear implants, you're leaving them to really figure out all of that new sensory input on their own, and can be really overwhelming. So they need help to make sense of that. So I'm looking forward to quite a few more years of therapy with Maddie to help her not only develop, but help us to even hopefully go beyond her just biological age abilities. For her to be able to communicate above that would be amazing. We can just see some of the potential for her to do that, which makes us really excited. So we want to keep going. We're so grateful. Megan Nelson is our therapist at Nemours. We don't know where we would be without her.
And the last question is for you, Dr. Pritchett. Why does CMV target the hearing structure, particularly during reactivation? And at what point or age can we expect the risk of hearing loss to subside?
That's a really informed question. I believe saying target is perhaps, I don't know if that's the best term, but we certainly see that it's affected in ways that we can measure and monitor more readily than some other areas, right? As I had alluded to, it looks like there's some balance issues that are there. And I think the ear typically has been a very protected and preserved organ, right? But when you have an entity that can affect the blood supply, when you have an entity that can affect the actual motor mechanism that allows that electrochemical gradient to be designed, it makes the ear vulnerable in so many different realms, right? The ear is complicated, and so one little thing can have a domino effect, and I think there's some vulnerability that was there. I'm sorry, the second part of that question, Kristen, was what now?
The second question is, at what point or age can we expect the risk of hearing loss?
Yeah. So that depends on whether or not the child has hearing loss identified early or late. What we're seeing is that early onset hearing loss is more likely to progress over time to a level of severe to profound loss. For children who have delayed onset losses, that is not quite the same risk. There are children who can develop delayed onset loss into their teenage years, right? But what we've seen in some of the larger studies have said after that fifth or sixth birthday, the likelihood drops off. And so the recommended approaches now really have folks following pretty closely out to 5 or 6 years. We would not be able to say there isn't any chance, but the incidence starts to look more like children who have hearing loss that are not CMV affected. That can just happen, right? There's a certain amount of just unfortunate hearing loss that happens and we don't know what caused it. And so after that, fifth, sixth year, you start to see more similar rates over time.
And I believe that was our last question. So we just want to thank everybody for attending the Tuesday talk, and to please visit our website to register for upcoming dates. There's also on the final slide there available resources at the website.
Thank you.